Welcome back. Today we're doing another episode on our Intro to Jail Mental Health series. This time we're talking about the medical intake process and why it's the most important 10 minutes a person will spend in jail. So when a person comes into jail, there's a whole process that has to be completed. This includes getting fingerprinted, having your photo taken, otherwise known as your mugshot, your property is inventoried, and among other things, you have to talk to a medical professional to complete an evaluation. Part of the reason for a medical evaluation is that the jail has to agree to accept the arrested person. If the person comes in with what seems to be a serious issue, let's say they somehow broke their arm during the arrest, or there was a motor vehicle accident and the nurse suspects internal bleeding, then most jails are not going to accept that person. You might be thinking, wait, jails can't decide not to accept that person, they were arrested. In fact, there are situations in which they can refuse to admit someone. The most common of these is if the medical staff deem the person too unstable to be safely housed in the jail. If that's the case, they will refuse to accept the person until the arresting officer takes them out to a hospital for medical clearance. When it comes to this medical screening in the jail, there are two ways you can do it. The first option is to do a pre-screen, which is extremely brief, usually only 1 or 2 minutes long, and it's to determine if it's safe to have the person in the jail. The arresting officer can then leave, and the new inmate can wait in a holding area until there's time to do a more thorough medical evaluation. The other option is to do a full medical evaluation for every inmate right when they get into the jail. Now, the first option is better for police officers because they get to leave the jail sooner. The second option is better for medical staff because they only have to see the inmate once. There isn't really a wrong way to do this, but you have to weigh whether you want to prioritize getting your officers back on the road quickly or maintaining efficiency with your medical and booking staff. So anyway, let's talk about the evaluations themselves. In my jail, these evaluations are done by registered nurses, but other jails might use medical assistants, EMTs, or nurse practitioners. They could theoretically use doctors, but as we've discussed previously, this would probably be a poor allocation of resources. The medical evaluation should be comprised of several parts. The assessing clinician should ask about any current medical problems, any medications, any allergies, any recent injuries, and a bunch of other standard questions. This should include any current mental health diagnoses or medications. They should ask the inmate if they're currently seeing a therapist or medication provider. If so, they should find out what pharmacy the person gets their medication from so that they can call and verify it. If you ever have to call a pharmacy, you want to take down the name of the person you spoke to, as well as all the details about the medication, doses, administration instructions, and most importantly, the last time they picked up the prescription. A lot of times inmates will tell you that they take this or that medication, but then you call the pharmacy and it turns out they never actually picked it up, or the last time they picked it up was 3 years ago. I see a lot of inmates say they take medication which is not actually prescribed to them. They say, oh yeah, I take Xanax or I take hydrocodone, as if we're not going to take the time to verify that. Anyway, all this information is important for your prescribers when they're considering whether to restart or bridge a prescription inside the jail. The next set of questions in this evaluation are about substance abuse. You always want to ask about substance abuse because at least half of all the people booked into jails have a diagnosable substance use disorder. Common drugs of abuse like alcohol, benzodiazepines, and stimulants also have interaction effects with a lot of other prescription drugs, so that's good to know. Now, a couple important notes about screening for substance use. As we've discussed before, it's common for inmates to lie about their substance abuse. They may have been arrested for possession or DUI, and they don't want to incriminate themselves. There's also a lot of social stigma about substance abuse, especially things like crack cocaine and methamphetamine, so sometimes they just don't want to feel embarrassed. Because of this, you always have to assume that inmates are underreporting their substance use. If an inmate says they drink 2 to 3 beers a day, you should probably assume that they drink 6 or more beers a day. In jails, we are in the business of keeping inmates alive, and this means caution is the word of the day. A quick reminder that alcohol is the most dangerous drug to detox from, so failing to notice a possible alcohol use disorder during intake evaluation is a big deal. Now, you might be wondering, if inmates lie about their substance use, why don't you just drug test everyone who comes into the jail? And that's not a bad idea, but a few thoughts. First, you're going to get a substantial number of inmates who just refuse to participate. You can't really compel someone to give you a urine sample, and most jurisdictions won't let you take a blood sample without a really good reason, and probably also a court order. So that's the main reason you can't drug test everyone. Another thing worth considering is that most urine drug screens are actually pretty narrow in terms of what they can detect. They'll usually pick up commonly abused drugs like alcohol, cocaine, THC, and some opioids. However, they don't all detect synthetic cannabinoids, also known as K2, spice, etc., kratom, certain benzodiazepines, gabapentin, xylazine, ketamine, certain hallucinogens, and importantly, they don't always detect the entire range of opioids. For instance, some tests can detect morphine, but not fentanyl. So unless you have a very robust drug screening method that looks specifically for these things, there's always a chance you're going to miss something. A negative drug screen does not rule out the possibility of intoxication, withdrawal, or substance-induced psychosis. A quick editorial aside, I'm aware that some jails do not routinely drug test inmates at booking on suspicion of drug abuse. The rationale I've heard for this is that it takes too long, or it's too expensive, or if we drug test people and something comes back positive, then we have to put them through the detox protocol, which is more work for our staff. Now, I have moral and ethical concerns about this. Half the people who come to jail have substance abuse issues. We know this. We also know that they lie. How much extra effort can it really be to at least try to get a urine drug screen? It takes less than a minute for an inmate to pee into a cup. I think we have an obligation, given that we're charged with providing care for these people while they're incarcerated, to at least try to get a drug screen done. And if you're not convinced by the moral argument, let me give you a monetary one. Drug screens cost about $30 a pop. So if your jail booked, say, 10,000 people in a year, drug testing everyone would add about $300,000 to the cost of running your jail. And budgets are tight, right? Who wants to pay an extra $300,000? Well, you have to weigh this against the cost of someone dying in your jail. If someone dies in your jail and you get sued, which is extremely likely, then you could end up having to pay a lot more than $300,000. Well, we don't need to worry about a lawsuit because we didn't do anything wrong. And you might be right that you didn't do anything wrong, but getting sued incurs steep costs even if you did everything right. Your jurisdiction and your medical contractor has to pay their attorneys or pay contract attorneys tens of thousands of dollars to defend themselves from a lawsuit. For this reason, a lot of county and municipal governments will settle lawsuits without ever admitting fault because it's cheaper to just pay someone $100,000 to go away than it would be to take a case to trial, even if they know they'll win. And trial's always a risk. You could lose even if you did nothing wrong, and that loss could cost tens of millions. Suddenly, a couple $100,000 to drug test people doesn't sound so expensive. Anyway, aside over. The next set of important questions in an intake evaluation are about mental health and suicide. We're going to go into suicide risk assessments in a separate video because they're a big topic in jail mental health, but the reason medical staff will ask questions related to mental health I won't tell you when or in what facilities these occurred, but I'm aware of 3 jail suicides in which the inmate was directly asked if they were having suicidal thoughts, and they denied it, and they had no other overt risk factors for suicide. We do our best, but not all suicides are preventable. Suicides occur 4 times more frequently in jails than they do in the community. Jails can make people feel hopeless, and they're filled with people who are going through the worst time in their lives. So, like I said, do your best to screen for this, be risk averse and cautious, but don't beat yourself up if you did your best and someone completes a suicide in your jail. We're going to do an episode on self-care for people working in jails sometime in the future, so stay tuned for that. Back to the assessment. If possible, it's a good idea to get some basic information about the inmate's living situation and any emergency contacts. Some of this information is helpful for data analysis, which we'll talk about later when we get to jail systems analysis, but it's also important for discharge planning. If someone is homeless and has nowhere to go when they're released, I'd like to know this up front. If your area is anything like mine, the options for homeless shelters and recovery housing are limited. The sooner we know about these issues, the sooner we can get re-entry involved and start planning for the inmate's release. This is especially important to do during periods of extreme weather. It gets pretty cold where I live, and if an inmate is released in February with no place to go, they're going to be in a dangerous situation. It also creates a revolving door problem because the person is being released into the cold, and to get warm, they loiter at the gas station or the drugstore until they eventually get arrested for trespassing. And then they're right back in the jail again. I've seen it happen several times where a person is released without a place to stay, and they just refuse to leave the jail lobby until they eventually get arrested again for trespassing. It's pretty ironic to be arrested for trespassing out of jail, but this is what happens when jails are not only the new psychiatric hospitals, but the new homeless shelters as well. That's the gist of what happens at medical intake. Now I want to talk about a couple other things that happen based on the outcome of the assessment or as a result of the process. One thing that can happen is that the person being booked into the jail is too mentally ill, too intoxicated, or otherwise has some sort of problem that prevents them from participating in the medical assessment. This is when things can get a little bit tricky, and you need to have good communication and good relationships between your medical, mental health, and corrections staff. For example, let's say you have someone who comes in psychotic, ranting about aliens and chips in their brain, who refuses a TB test and refuses to talk to nursing staff, and who is also threatening to harm officers. So now you have medical who wants to put the inmate in medical observation because we don't know if he has a contagious illness, mental health who wants to take the inmate to the mental health unit because he's psychotic, and corrections who wants to put the inmate in segregation to stop him from hurting someone. You have to put the inmate somewhere. I'll say that you shouldn't be putting psychotic inmates in segregation, that's bad for them and it's not safe. As to whether an inmate like this should be placed in a medical or a mental health section, you'll have to determine this on a case-by-case basis. We're running a bit long at this point, so I want to wrap this up. The last thing I'll mention is that it's important, if you can, to try to control how many inmates are arriving at the jail to be booked at a time. Obviously, you can't predict when everyone is going to be arrested, but you might be able to work out when you get new arrivals from other jurisdictions or when your police department conducts warrant sweeps. And if you aren't familiar with this, warrant sweeps are when officers go out to look for people who have active arrest warrants, usually for failing to show up for court. The police then round up a bunch of these people all at once, resulting in a deluge of new inmates waiting to be booked and medically evaluated. The reason I mention this is that you don't want to be in a situation in which too many inmates are getting stuck in a holding area waiting to get processed into the jail. Let's say it takes 30 minutes for medical staff to do their interview, all of their paperwork, call the pharmacy, talk to the on-call physician about what meds to give, and work with classification to determine where the inmate can be housed. If you only have one nurse working the booking area, and you all of a sudden have 20 inmates arrive at your jail, it's going to take 10 hours to process all these people. In the meantime, you might already have people who are waiting, you might have more people who arrive after this. If you're not careful, these types of log jams can occur and you end up with people sitting in the holding area for 12 or 24 hours just waiting to get booked in. These are people that you haven't done a thorough medical evaluation on. So in this time, they could start having symptoms of detox. If they have diabetes, their blood sugar could get messed up. They could have an injury upon arrest that you didn't have time to look at. Basically, it creates a dangerous situation for the inmate and a potential liability situation for the jail. So you want to make sure your medical intake department is sufficiently staffed, and if possible, avoid having lots of people dropped off at your jail all at once. So that's good enough for today. That's the basics of the medical intake and why the interview is the most important 10 minutes that a person will spend in jail. I'll include a link in the description to a document I wrote that covers the basics of what should be asked in a medical assessment. This isn't exhaustive, but it should get you started. I think in the next one we'll probably talk about suicide prevention, but that's all the time we have for our session today. I'll see you next week.